Hello, everyone, and welcome back to the Health Technology Assessment International Meeting 2021. I'm Blythe Adamson, Director of Quantitative Sciences at Flatiron Health. And today we'll be unpacking a challenge to understanding cancer treatment effectiveness using real-world data. And the root of this challenge lies in the frequency that people receive imaging or scans for their disease progression. Now, in a clinical trial, this may happen on a fixed schedule, every 6 weeks for the first 6 weeks, and then every 9 weeks. A patient who's receiving a cancer treatment may come in for imaging to see if their disease has progressed. But in the real world, clinical guidelines like NCCN don't recommend imaging as frequently as clinical trials. And many have wondered if the frequency that people receive imaging differs depending on the treatment that they're receiving. So it's very plausible that someone receiving an infusion who needs to come into the clinic more often is also going to be scanned more often since they're there at the same time. Yet you might expect an oral therapy, which doesn't require you to come into the clinic as often. Someone receiving that treatment may be scanned less often. And so when we have the job of assessing value and understanding the comparative effectiveness of treatments in the real world, we have to take into consideration how the measurements of the outcome and the differential timing of when we're taking those measurements could influence and bias our assessment of the evidence. And if we think about measuring comparative effectiveness and estimating a hazard ratio between two different treatment arms, there is a true progression that can happen within each individual in the real world, where inside their body a disease progresses. But then the disease might not actually be observed until the next scan date. And in this analysis, we are going to be describing this as the observed progression-free survival. So if a treatment group is receiving imaging less frequently, it's going to take longer to detect that disease. And if they're being imaged more frequently, then it'll be a shorter time to detection of that true progression. And the study that we designed to understand the susceptibility to this bias and quantify it involves two parts. So first, a real world data analysis, looking at the real scans of cancer patients who are receiving these treatments. And then second, a simulation model to quantify the amount of bias that could be induced in an extreme or clinically plausible situation. So I'll discuss both of these today and begin with the real world data analysis. And there are a few spoilers that you might see here. The patient population that was selected for the real world analysis was advanced and metastatic patients with non-small cell lung cancer, or NSCLC. And we identified these patients using electronic medical records from the United States, a database that had more than 2 million cancer patients in it. And we specifically narrowed this set down to patients with this advanced cancer type seen after 2011, who received at least one anti-cancer systemic therapy and had documentation of radiographic imaging assessments during that time after treatment start within their electronic medical records. And from a random sample of that population, manually abstracted the corresponding documentation of the scan dates and results. And this left us with a real world study population with 3,118 patients in it, with some of their baseline characteristics described here. And the hypothesis really was not rejected. We saw evidence that the frequency of scans in the real world did differ by treatment type. So in this figure, you'll see that for a patient who was receiving, an average patient receiving EGFR TKIs, one of the cancer treatment types, The average time between an imaging assessment was about 15 weeks. And on the other end of the spectrum, a more frequent imaging was seen for patients receiving platinum-based chemotherapy, where they went on average, about 10 weeks in between scans. And while that was in first line, we did a sensitivity analysis trying to understand, does this really hold up in later lines of therapy? And now in this figure, which now we're using an x-axis of the probability of receiving imaging within an observation window, it does confirm the same rank order in terms of average frequency that we found in first line to be consistent in second line therapy. So that was our real world data analysis. We described the frequency that patients with non-small cell lung cancer are receiving radiographic imaging in the real world, and showed that this really can differ by treatment type. So now, what are the implications of that? What's the impact and influence on real world estimates of treatment comparativeness? So this is where we're going to dive into a simulation model to be able to isolate the effect of that difference in frequency if we were to define the true and the observed progression-free survival that corresponds to it. And we designed a discrete event simulation model that generated the patient journeys for many individuals. And we defined, based on assumed or based on our inputs about what the survival curves looked like for each treatment type, what the true progression date would be for each of these simulated individuals. And then, dependent on which treatment they received, also generated a sequence of imaging scan dates for each of these individuals, where the first imaging scan date that followed a true progression event for that individual would help us understand when that progression would be observed by the physician, captured and documented as the outcome. Another way we can think about this is through the lens of false negatives and true positives, where the health states that a patient can exist in include, within having truly progressed, a false negative health state where that progression has not yet been observed, and the assumption is that they may not have progressed yet, and then a true positive where the moment in time of passing into that health state begins at the date that the imaging assessment was made. And the outcomes of this simulation study, the ways that we defined how we were going to quantify bias in this study is through the primary metric of the percent bias in hazard ratio. So this is looking at what the true hazard ratio would be between these comparators and then the observed hazard ratio. We also looked at a secondary outcome, which is the percent of conclusions that differ. So if we run 1,000 hypothetical cost effectiveness or comparative effectiveness simulations, each having 1,000 patients within them, what is and then we layer into that the bias of these differential scan frequencies. How many of these comparative effectiveness simulations would have come to different study conclusions? Now, it may not be a conclusion that's in the opposite direction. It may take a study where the true underlying answer is that these two drugs are meaningfully different from each other. But because of the bias in the frequency that we're measuring the outcome, we cannot reject the null hypothesis. And so the conclusion differs because then we can no longer draw a statistically significant, meaningful difference between these two drugs. And this is where the real world evidence, the output from the analysis of the first part of our study, melds now into and plugs directly into the simulation model. Now, in our main analysis, we defined a very extreme hypothetical situation, where the probability of receiving a scan within an observation window was maybe 65% in one group and 50% in another group. So a pretty big difference in the likelihood of receiving scans. And then in addition to that, extreme hypothetical example, we thought it would be more clinically meaningful to define a set of case studies based on clinically plausible comparisons that use the output from our real world data analysis to inform a more generalizable or representative distribution in frequency of outcome measurement. So here are some results. The extreme hypothetical example, here we have drug A with a median time to progression of 4 months, drug B 5 months. We're going to throw into this the bias, the scan schedule dates, where for drug A, patients are being scanned on average every 12 weeks, and for B, every 9 weeks. And this gives us a hazard ratio of 0.86 as the observed hazard ratio based on what we would expect from real world data, and a true hazard ratio of 0.8. So this is biasing it towards the null hypothesis here with a difference of 7%. And in this case, 30% of the simulations had conclusions that differed, where they were found not to be a significant difference between drug A and drug B, when the true answer is that there was a clinically meaningful difference between these groups. So of all the case studies that we defined and ran as scenarios to understand the combination of factors, one of the clinically plausible case studies that we looked at compared chemotherapy to PD-L1 inhibitors. And in this case, chemo would have a progression-free survival of 6 months, PD-L1 as 12 months. So those are the inputs we defined to be the truth. And then layered into that, the imaging frequency we had observed in real world data, which was 10.6 weeks between scans for chemo and 10.8 weeks for PD-L1. And in this scenario, there's a very small difference in the frequencies, and we see that play out in the observed hazard ratio of 0.51 compared to the true of 0.5. So a very smaller amount of bias, and none of the simulations in this analysis led to different conclusions than the truth. And in a sensitivity analysis, we can tease apart and understand some of the main drivers for this. And really at the end of the day, the biggest factor is how large of a difference in the frequency of measuring the outcome are we observing between these two groups. And this, I would say, studies that are more susceptible, more vulnerable to this type of bias would be ones where the outcome happens relatively quickly. So in advanced lung cancer, for patients to reach death within 6 months sometimes means that the comparative effectiveness studies can be very sensitive to how frequently patients are being assessed in the real world. Whereas in another disease like maybe breast cancer, we may expect with the longer follow-up time and longer life expectancy of patients that a clinical setting like breast cancer may be less susceptible to differences in the outcome measurement. And a framework that we can use biostatistically to think about the possible errors from this differential measurement in the outcome really is thinking about type 1 and type 2 errors, where bias in the conservative direction might lead us to conclude, that in this real world analysis that these two drugs, we cannot show that there is a clinically meaningful difference in outcomes. And we could have an error leading us to make that decision when underlying there really is a true difference. We just were not able to detect it. Versus an anti-conservative, where there in truth is no difference between these two drugs, but it is only because of the difference in how frequently we measure the outcome that we now think there is a meaningful difference when there is not one. And so this is a framework we can use to think, okay, if the control group that we expect to not perform as well is the one that is being scanned less often, that may lead us to a more conservative direction of the bias. And researchers should take extreme caution if there's both a large difference in the frequency of assessment and the inferior treatment group is being scanned a lot more often. And so for learnings, this is just a summary of some of the things that we've talked about so far, of studies, comparative effectiveness studies that could be susceptible to this type of bias in cancer treatment comparative effectiveness. And studies are more susceptible to bias also when the true effectiveness is small, when the hazard ratio is closer to 1. And they're less susceptible to bias when the differences in the scanning schedules are very minimal. And as researchers, this really begs us to open up a lot more scientific discussion about the best ways that we can be adjusting for and correcting these differences in scan timing to better isolate rigorously what we think the true comparative effectiveness is for these treatments in the real world. So I thank you so much for your time. My contact information is here for any follow-up questions. And I look forward to enjoying the rest of this HTAi international meeting. Thank you.